For this week's infectious disease, I chose chlamydia and gonorrhea. So both chlamydia and gonorrhea are sexually transmitted infections. You can see both the types of bacteria that are caused from these infections. Chlamydia, there's about 540 cases per 100,000 individuals in the United States, so that's about 2.9%, while gonorrhea has about 179 cases per 100,000 individuals, so that's about 5%. Both of these infections are transmitted sexually via vaginal, anal, or oral intercourse, and then you can transmit both infections to the newborn via delivery. Those who are at most risk for STIs include those that are under 25 years old, current or recurrent sexually transmitted infections, any new sexual partners, partners who have been with other people, male sex partners who have been with other men, those who use injectable drugs or who have sex with those who use injectable drugs, exchange of sex for drugs, inconsistent use of pregnancy prevention methods, so for those who don't use condoms or other birth control methods. It's common that if you have one of these infections, that you also have the other one. So subjective presentation of a patient with chlamydia, they would have vaginal discharge, bleeding after sex, painful urination, and some lower abdominal pain. They also would have purulent cervical discharge and some tenderness upon abdominal examination. The subjective signs for gonorrhea are very similar. You have tenderness in the Bartholin's and Skewon's glands, as well as the cervical discharge. Both chlamydia and gonorrhea are often asymptomatic. Because both of the infections are known to be silent and asymptomatic, there's little to no objective clinical presentation observed in these patients. You would have the vaginal swab results from both of these infections, as well as seeing white blood cells noted in chlamydia microscopic swabs. Some risks to the mother for chlamydia include preterm labor and birth, preterm rupture of membranes, ectopic pregnancies, spontaneous abortion, stillbirth, postpartum endometriosis, and pelvic inflammatory disease. Ectopic pregnancies occur due to past infections of sexually transmitted diseases. Those infections destroy the tubal cilia and then leads to fibroids in the fallopian tubes. This causes ectopic pregnancies to occur more often. Maternal risks for gonorrhea include preterm birth, ectopic pregnancies, and PID as well. Fetal risks for chlamydia include conjunctivitis, pneumonia up to 3 months after birth, and mortality. For gonorrhea, there's fetal growth restriction, conjunctivitis, polyarticular arthritis, gynecosemia, and genital infections. As for delivering the baby, you can either have the babies vaginally or through C-section. There's a greater risk of transmission vaginally, but it also can occur with a C-section. In chlamydia, there's a 50 to 75% chance of passing the infection via vaginal delivery, while it's 30 to 50% rate of transmission for gonorrhea. With the use of erythromycin eye ointment at delivery, there has been a significant reduction of ophthalmic infections in newborns. Because the infections are silent, any of the symptoms experienced by the patient could be mistaken for other STIs or any condition that has abdominal pain or urinary issues involved in that diagnosis. These are some of the diagnoses that may be mistaken for a chlamydia or gonorrhea infection. Diagnosing chlamydia, the CDC recommends that those who are at increased risk should be tested at their first prenatal visit. This also goes for gonorrhea, but it's often done anyway on everyone, not just those who are at increased risk. You use a nucleic acid hybridization testing with an endocervical or vaginal swab. So these are swabs that are taken. You can either have them at home kits, or there's also, you can just do it in the office. The at-home gnats are equivalently sensitive and specific to the ones that are used in offices by clinicians. You can also do a urine collection for chlamydia, but it may not detect the infection. For those who are at increased risk, they would be retested in the 3rd trimester for both chlamydia and gonorrhea. So pharmacological treatment plans for chlamydia are on the left-hand side of the slide. The 1 gram of azithromycin, the one-time dose, is the preferred method from the CDC. All of the others are options that one may take if they're preferred by patient and if the clinician thinks those would be better options. For gonorrhea, the 250 milligrams of ceftriaxone IM and 1 gram of azithromycin PO is the preferred method for treating gonorrhea. So the patient would be treated with these medications as well as the partner. The partner will get tested for chlamydia, gonorrhea, HIV, and other STIs, and then would be treated with an antibiotic to treat their infection. It's important that those who are being treated with antibiotics should abstain or use a reliable barrier such as a condom during sexual intercourse. They should abstain from having sex for 1 week after completing their antibiotics, or make sure that they're using a barrier. Education with the patients would include abstinence, reviewing any risk factors, and explaining to the mother why they would be retested. And they should continue prenatal visits normally unless a reinfection occurs. Women who are treated for chlamydia should be retested 3 to 4 weeks after treatment. Once they're cured, they should also be retested 3 months to ensure that infection did not occur. For gonorrhea, they'll be retested, and once they're cured, they'll have another retest 2 weeks after their treatment. These are my references. Thank you for listening. I appreciate any questions.